Well, I think we could get started. We've got quite a few people on now. So good morning, everyone, and thank you all for joining. Some of you may not be familiar with me. My name is Tasmi, and I'm on the at Vector. Today, we have Dr. Mohammed Mamdani, who will be speaking on applying data science to healthcare, focusing on purpose, infrastructure, methods, application, and impact. Dr. Mamdani is Vice President of Data Science and Advanced Analytics at Unity Health Toronto. His team bridges advanced analytics, including machine learning, with clinical and management decision making to improve patient outcomes and hospital efficiency. Dr. Mamdani is also a professor in the Department of Medicine at the Faculty of Medicine, the Leslie Dan Faculty of Pharmacy, and the Institute for Health Policy Management and Evaluation at the Dalawana School of Public Health. He's also adjunct senior scientist at the Institute for Clinical Evaluative Sciences and faculty affiliate at the Vector Institute. He's also the founding director of the Applied Health Research Center, the Lika Shing Knowledge Institute, which is Toronto's leading academic research organization focused on the design and implementation of multi-center clinical research initiatives. Welcome, Dr. Mamdani.
Great, thank you very much. It's great to be here, and sorry I had to go through that intro. I'm gonna try and make this talk very practical. My background is I'm a pharmacist by training, did clinical work for a while, then really went into research, so a researcher as well. I also have an MA in econometric theory of all things, and a public health master's in statistics and epidemiology. And I've been more or less obsessed with application and impact, and that's really what this talk is focused on. So for people who really want to know cutting edge research around neural networks, I'm sorry, this is probably not the talk. But for folks who actually say, all right, well, what are we doing with data science, and how does it actually make a difference to people in healthcare? This may be more up your alley. So the objectives. I'm going to keep them very simple. The first is to review the term data science in healthcare, just so we're all on the same page. Because I, in my discussions with a lot of people, I get the sense that some people say data science is this thing, and other people say it's another thing. So I'll tell you what my perspective is. The second is to provide perspectives on the types of healthcare issues that data science may be able to address. The third is to review actual examples. I'd like to actually go through what are some use cases and some stuff that's actually happened, so you can get a feel for what I'm talking about. And then the third is to review a framework for data science application and impact assessment in healthcare. And you'd think that this would already be available, but I've had a hard time finding something that really works in practice. So maybe we'll start with some of the basics around, at least from my perspective, what is data science? If we look at Wikipedia, which is a source of all truth, it is defined as the concept that unifies statistics, data analysis, machine learning, and the related methods in order to understand and analyze actual phenomenon with data. Of course, if we go to, I think, maybe more practical examples, definitions. Hal Varian is chief economist at Google and professor at Berkeley. The definition there is the ability to take data, to be able to understand it, process it, to extract value from it, to visualize it, to communicate it, which to me is pretty broad. And that's kind of where I think as well, it should be fairly broad. So if we think about the cycles of data, from capture to maintaining it, to processing it, to analyzing it, to communicating it, we're all data scientists, I guess, to a certain extent, aren't we? But I kind of view the field of data science as much more broad than simply doing AI or machine learning models. It's around simple things like even data entry or data acquisition processes. That's data science in my mind. And even communicating these results, having that understanding of what models mean or what a confusion matrix is, and being able to communicate that to end user, that's data science as well. So I'm coming in with a very broad definition of data science. So lots of stuff goes in, as with the previous slide: machine learning, database, data processing, data mining, visualization. Again, very broad. There's a lot of hype in healthcare around data science and AI. You'll see lots of titles out there in the popular media. AI beats doctors at cancer diagnoses. Self-taught artificial intelligence will beats doctors at predicting heart attacks. Your future doctor may not be human. This is the rise of AI in medicine. And artificial intelligence will redesign healthcare. And sure, I mean, some of it's cute, but I'm not really sure if we should be hyping it so much. There's a lot of potential for machine learning, for data science, for AI, but I think we're a bit of ways away from really, really realizing it. And the reason why I say that is we just have to look at some of the failures that are out there. And yes, of course, people can argue there have been lots of successes. Amazon's changed retail. Most popular hotel chain in the world is not Marriott, it's Airbnb. We've got Uber that's using machine learning and has just radicalized the taxi industry. Sure, lots of great successes. But I would also argue that there's a lot of failures we may not hear about. And what are some of these failures? Well, I mean, one example that I was really kind of concerned to hear, and some people may think it's comical, but it's actually very concerning, is Microsoft's Twitter chatbot Tay. I'm sure many of you have heard about this, but just very briefly, this chatbot was created by Microsoft and they put it out in the Twitter universe. And of course, within 16 hours, the Twitter trolls taught it to be extremely racist and misogynistic. And they had to remove it. So what I guess people didn't quite maybe understand is, yeah, the world's not perfect. It's not ideal. People aren't going to hold hands, sing kumbaya, and hope for the best for Tay. There are people out there who are going to corrupt it, and that's reality. Of course, then we have IBM's Watson. And again, many of you have probably heard of Watson as well. The success was fairly limited. So two of the more famous places out there, MD Anderson and Sloan Kettering out in New York, didn't do quite well there. And why wouldn't it do well? I mean, this is a great idea. You've got this massive supercomputer, you've got these AI algorithms, you've got Watson coming in and saying, hey, I'm going to ingest a whole bunch of literature, I'm going to look at patient-specific characteristics, and I'm going to make recommendations. Well, unfortunately, what happened for a lot of the clinicians who are on the ground practicing, they said a lot of your recommendations don't make any sense to me. They're really not very helpful. And some of the ones that do make sense, you already made that decision yesterday. You probably are using data that I already know about that doesn't help me because it wasn't really proactive. So it didn't really go over as well as maybe it should have. And sure, there were some wins that identified some cases where it helped, but by and large, it wasn't really felt to be that helpful. And the last example I'm going to use is around a case in diabetic retinopathy. So this is for patients who have diabetes, they get eye disease, and you can go blind. So it's actually a pretty serious condition. And many will argue that if you catch this early enough, there are interventions. I mean, they're not all successful and powerful, but there are interventions that you can then start employing so you don't go blind, which would be good. So how do you actually diagnose diabetic retinopathy early? Well, you go to an eye doctor, so an ophthalmologist, or your endocrinologist will refer you, and some of them can do eye exams, where the thought here is you take a scan of your eye and you see if you have diabetic retinopathy. It's all about pattern recognition. And so Google thought, you know what, why don't we actually just create an algorithm that does this? And they did, and it was fantastic. The performance was wonderful. The problem that we have is a lot of research groups, they may not take into consideration poor lighting conditions, for example, in many clinics, especially in developing countries. But even in developed countries, it's not really ideal. You also have all sorts of issues around patient waits and the flow, the workflows that are involved. And we don't quite think through these things. So this clip here talks about an experience where Google tried to implement their AI algorithm in diabetic retinopathy in Thailand, and it did not go well. People had to come back for several visits because the scans weren't high enough quality for the algorithm to read it. And of course, the docs and the nurses there were like, yeah, we've seen this 100 times. You don't need to come back. We know what the diagnosis is. So it didn't quite mimic what you would actually normally see in practice, and hence it didn't really succeed. So, this is where we start worrying a little bit. And people may say, all right, well, it's no big deal. You know what? You tried it. Nobody died. Nobody got hurt. Well, let me go through an example where it's not quite AI. It's a very simple clinical prediction rule. I think they use logistic regression in this paper, where basically the concept here is febrile urinary tract infection. So not the most glamorous thing to talk about, but basically it burns when you pee, and you start having these pains in your lower back, where that's indicative of kidneys. And then you say, oh gosh, I've got a fever, so I'm going to go to the emergency department. And so what happens when you go to the emergency department is the clinician assesses you and says, yep, febrile urinary tract infection. I have two main options. The first option is to send you home on antibiotics, and I'm going to hope for the best. The second option is to say, there's some complications that you get with febrile urinary tract infections, so I'm going to admit you. So you're going to be in the hospital admitted, and we're going to just watch and put you on antibiotics and make sure everything's okay. So those two options. From a hospital perspective, you typically don't want to admit patients unless you have to, for many reasons, costs and safety. As soon as that people get into the hospital, you're at risk for infections and all sorts of bad things. So it's better to actually be treated at home. But I think from a patient perspective, you also may want to be treated from home as well. So how do you make that decision? Well, the researchers here in this paper had said, we can actually create a risk prediction tool. And what it'll do is you put in some parameters and it will tell you if the patient should go home or if they should be admitted. Sounds simple enough, right? The kind of interesting part to all this is their primary outcome was, can we reduce hospitalization? And in fact, they did reduce hospitalization. But their secondary endpoint is, well, when this algorithm tells you to go home on antibiotics and versus being admitted, what happens to people who actually do go home? Do they come back because they had issues? Well, yeah, in this paper, this clinical trial had to be stopped early because the rate of people coming back to the hospital increased fourfold in the intervention arm. So the way they studied this again was they had over 30 sites. They randomized half of them to not using this tool and half of them to using the tool, and again, in a randomized way, fairly rigorous. And again, what they found was in the arm that used the tool, your comeback rate to the hospital increased fourfold. That's not good. So they said, this is a safety issue. We can't continue this trial. They had to stop it. So you actually ended up harming patients by using this tool. And that's the worry that I have, is that we always do this really neat data science stuff. Are we really even making a difference? And in fact, are we actually even harming our patients by implementing some of this work? Of course, there's a lot more to this story than I'm telling you. And this is where maybe the algorithms weren't at fault, but maybe we were as people. I'm going to highlight a few bubbles here. Where can things go wrong? And there's many more bubbles, but I'm going to conceptualize into 4 big bubbles. The research question, the data that's involved, modeling, and implementation. And I highlight modeling because I get very concerned about, especially our younger generation, our students. My experience has been is that some are very good, but we've had experiences, and this is with a couple of students from very reputable places, including one that's affiliated with Vector, coming in and saying, I don't worry about the research question data, just give me the data, I'm going to model it. It's the worst thing you can do. And it's one of the most arrogant things I've seen. Models can't fix things. So, if we start at the research question and we look at this example, first of all, one big problem is, did the researchers pick the right question? Because when you come to an emergency department, the chances of you being misdiagnosed are actually higher than you might think. We don't really do a good job at diagnosing febrile urinary tract infections very well in the emergency department. So if we can't even diagnose well, are you trying to tackle a problem that maybe you should go back to basics and improve your diagnosis properly? I would argue yes. you picked a very ill-defined problem. The second issue that this paper had was the data. Initially, their intent was, we really want to focus on 30-day mortality because some people do die from this condition, but there wasn't enough data. But at least they recognized it. The one other issue then became, well, there are some pretty important clinical features. They weren't captured in the data that was available. So then you have to step back and say, should I even do this? Because I'm going to miss quite a few important things, and it may mess up my model. The data may not really allow me to answer a poorly studied research question, or even a poor research question, period. So you've already started losing the battle here. Then you get into modeling. The kind of weird part is when I reviewed this case before, some people ask me, wait a minute, these guys actually build a urinary tract infection model on a pneumonia model? Well, yeah, they did. Actually, the basis of this model was based on a pneumonia severity index. And they removed the lab values and they did a few tweaks, but they later realized pneumonias are different from urinary tract infections, and maybe we should have actually considered those nuances a bit more in terms of how we modeled this thing, and not just trying to fit a pneumonia model onto this condition. And of course, the last thing that I want to comment on is implementation. They realized during the trial that the clinicians weren't really familiar with the prediction tool. And some may argue, well, shouldn't you have actually reviewed the tool, educated them, made them comfortable before you actually implemented and did the trial? Arguably, yes, but this is pretty common. We do this a lot. And in fact, 1/3 of low-risk recommendations were overruled. So there are quite a few times where the clinicians would say, no, I don't think so. I don't really agree with the tool. And so that then kind of says, well, have you implemented this right? So these are just 4 of buckets that I see that really contribute to, have we really implemented it well in a way that will help patients, that will be true to the intent of data science and AI? So that's just walking you through all the challenges here of how you actually do meaningful work that will really impact people. There's a lot of buzz here as well around AI and the momentum shifting. And this creates a lot of concern, right? And I hear this more and more as time goes on. There's a nice paper that was written in The Economist just a few weeks ago, and it highlights that an understanding of AI's limitations is starting to sink in. After years of hype, many people feel AI has failed to deliver. And that's concerning because there's so much resource put in. And if people start realizing, hey, wait a minute, we've been through this before. There's an AI bubble, it burst. We're going through the same thing. We're going to burst soon. That's really concerning because I see the potential here. I see how actually AI can make a difference fundamentally to how we do business and our patients that we serve. I just hope it doesn't too quickly. So now you're probably thinking, great, Mohammed, you're talking to us on a Friday, you're just a bowl of sunshine and you're making us feel really great. Well, no, I do think there's a lot of potential here. And what I want to talk a little bit more about is knowledge translation and research in healthcare. And I'm not sure what the format here is, if people just jump in and ask questions, or if we leave it to the end, but feel free to raise questions as we go along. So this whole concept of knowledge translation and research, I want to separate the two a little bit. How do we define knowledge translation? Well, in healthcare, I think a fairly well-accepted definition is the CIHR definition, the Canadian Institute for Health Research definition. Knowledge translation is a dynamic and iterative process that includes the synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians, provide more effective health services and products, and strengthen the healthcare system. I'll let you read the other stuff. I never really understood that definition that well, to be honest. For me, it's about how you actually get research into practice in a meaningful way with all the nuances and the messiness and the dirtiness of the real world. That's really all it is to me. Now, researchers, on the other hand, and I'm one, so I will be the first one to raise my hand and say, yep, that's me. Common research practices generate research and hope somebody uses it, but If they don't, it's not that big of a deal. I got my publication, I have some grants, and I'm going to get promoted. So that is my lens. Well, that's a problem, right? Because I think if that's your mindset, great, don't expect to make a difference because that's not your goal. Your goal is you're going to get publications, you'll speak at incredible conferences, you'll get promoted, and you'll be heralded as a visionary. Wonderful. That's great. But again, my focus is how do you actually get this into practice? And there's a huge disconnect. So I'm going to actually talk about this in a lot more detail. How do you design research for end users? So if you look at this cartoon, despite the valiant efforts of the research group, the insulin suppository still had one major drawback. And I'm sure most of you know what a suppository is, but for those who don't, this is how you have, rectal insertion of medication. And that would be very uncomfortable. In this case, the idea is wonderful, but the execution will not go over well for obvious reasons. I'm going to talk a little bit about our hospital. Our network is actually Unity Health Toronto. We are composed of St. Joseph's Hospital in Toronto, St. Michael's Hospital in Toronto, and Providence Health. And I want to focus on St. Michael's because that's where we initially built our infrastructure. We're a tertiary care teaching hospital in downtown Toronto, established in 1892 with the founding goal of taking care of the sick and poor of Toronto's inner city. So we're known as the inner city hospital in Toronto. We're one of two adult trauma centers in the Greater Toronto area. We have about 460 plus beds. It's more now because we're just opening up a new tower. And numerous outpatient clinics. We have over 6,000 staff, over 900 physicians, over 1,600 nurses. Approximate annual patient volumes. We've got closer to about 80,000 emergency department visits. Of course, it's lower now with COVID, but over 500,000 ambulatory visits, over 25,000 inpatient visits. I'm giving you these numbers because you can just get a sense that there's a lot of patients involved here. We've got 9 years of historical data, so multiply that by 9, 10 now, I guess. That's actually a pretty decent base to work with. We have a research institute, the Lee Cushing Knowledge Institute and Canadian Research Center, with over 200 investigators and over 800 staff, and we're fully affiliated with the University of Toronto. So end users, this is what we have to really focus on if we want implementation. We've got two basically big camps of end users. The first are our administrators and our manager types who do the day-to-day operations and say, you got to do X, you got to do Y. They really look at things like, all right, how do I optimize what I'm doing? So at our place, we actually have several types of data scientists, and I'll talk about that in just a bit. But it's magical how sometimes when I work with computer scientists, they feel that they've discovered optimization when operations research engineers have been doing it for decades. So having an understanding that data science is very broad and we can actually work with other disciplines would be really important. Costs become important. Performance indicators, quality of care, patient satisfaction, we're obsessed with things like that. And then of course, is our clinicians, our clinical team. And our clinical teams have slightly different perspectives. I mean, they're usually fairly aligned, but they're really obsessed by patient outcomes, patient quality of life, quality of care, and of course, as bad as it sounds, billings. You got to make an income, right? And the more patients you see, the more you can bill. So that's a mindset that these groups come from typically. How are decisions made? So how do our administrators and managers and how do our clinicians make decisions? And you think we're very evidence-based. I think at our academic center, we typically are, which is great. But in a lot of cases, it's kind of anecdote. It's my experience, what I believe to be true. And one would say, oh, well, that's not a good way to do things. Well, actually, it's not. I would defend that in terms of experience. It does matter. Because there are a lot of challenges with dealing with evidence. And some of you might think, well, you've got all these studies, all these randomized trials and all this sort of, yeah, we do. The problem with the evidence is, well, two things. The first is generalizability. And you'll have these issues when you're building machine learning models as well. Generalizability of the available evidence. Typically in healthcare, what we do is we have these randomized trials. Well, these randomized trials are samples of patients. In a typical randomized trial, with all your inclusion-exclusion criteria, you will typically exclude 80 to 90% of the patient population that you would normally see because of these inclusion-exclusion criteria. So these 80 to 90% that are excluded, you're only studying 10% of patients that you would actually see in practice. That's not really reflective of who you see. And on top of that, you're going to study 1,000 patients in a randomized trial. The results you get are for the average patient. I can tell you, most of us clinicians will say, the person I'm seeing right now is not the average patient. They're unique in their own way. So how am I supposed to generalize this sampled finding to my patient that I'm seeing right now? And that gets at specificity as well. Data quantity, when we actually start talking about data-driven projects, do we have the right data? So for a lot of problems, we won't have the right data to address them. And I would argue, don't address the question. Say, I'm not going to tackle this problem because I don't have the right data or enough data to do it. You know, we've had a couple of projects where, well, actually, I'll give you another example, COVID-19, right? So we've been hounded by people saying, oh, what are you doing with COVID-19 to predict A, B, and C? And at that time, I remember I had to turn to somebody and say, we've had 40 cases of COVID-19. Really? 40 cases. What do you expect us to do? We don't have that much data. There's not a lot of predictive power here to do some complex algorithms. We're going to stick to the basics and actually do what matters. So do you have enough data and do you have the right data? And if you don't tackle the problem. Data quality is always a big issue. Little examples, like when some of our variables, we see the docs enter 999 and we say, all right, well, that's just, you know, missing data or something that they couldn't bother. And in some cases they say, no, that's really important because the person just coded and we don't really, like, we don't have time or we don't know how to do A, B, and C, we just put 999. That's really important to know. Timeliness. So if you have 3-month-old data and you're trying to predict something for somebody who's going to walk into the clinic tomorrow and they were in the emergency department yesterday, your data didn't allow you to capture the most recent data, that's a problem as well, because that will fundamentally affect how you manage things. Evidence and data literacy. The clinicians and the end users and the management folks, they have to understand what these models can and cannot do and what the outputs are. And of course, culture. The community actually has to want to use these models. Otherwise, it's not going to work either. I can tell you the last two are incredibly big challenges in most institutions. So how can data science help in healthcare? Well, one is you can automate tasks. So rule-based models, heuristic models, machine learning models, optimization models. You can basically say, here's what you do. Instead of spending hours and hours and hours of time, I'm going to automate the whole thing for you. And that's very, very valuable. The other is to assist in clinical decision-making. Predictive modeling. So I can tell you when your patient's going to crash 24 hours or 40 hours in advance. That's really valuable. But I can do it better than clinicians. That's much more valuable. So there are many use cases. These are probably the two big buckets that I would focus on. So at our center, at St. Michael's Hospital and at Unity Health Toronto, we actually started our journey about 5 years ago and said, like, what do we want to see? And we kept our vision very simple. Make data and analytics an integral part of clinical and management decision-making to drive better patient outcomes and improve hospital efficiency. Two things, that's it. Improve patient outcomes, and improve hospital efficiency is code word for basically reduce costs. So better patient outcomes, reduce costs. The components of the vision: readily available, up-to-date, high-quality data, highly skilled data scientists, software and hardware, data governance and access models that are able to give us very quick access without any hurdles, and an engaged and data literate hospital community. So data infrastructure. We started out, as many hospitals do, with over 50 different data silos that don't talk to each other. It was a mess. We also had things like 4 sources of allergy data that disagreed with each other. Why do they disagree? Why do we have 4 sources? Because if you talk to the ED doc, they'll say, oh, they don't have a penicillin allergy. You talk to the allergist 2 days later, oh yeah, they do have a penicillin allergy. What do you believe? What's the source of truth? So we went through a 3.5 year exercise with IBM to create a pseudo data lake, and on top of that sits an enterprise data warehouse that was actually designed for analytics. And the kind of strange part is we didn't like models that were presented by the private sector because they didn't understand data science as well as we'd hoped they would. So we actually have to drive a lot of that design. We completed phase 1 of it in March 2018. And what happens is the process I'll outline very briefly, and I'll get to the real meat of the talk, is that we spent over a year with over 100 people at our hospital, clinicians, source systems experts, data experts, to say, all right, what are really important variables to you? And we identified over 2,700 variables in our source systems that people said, these are really important. And so we said, all right, well, what are the rules around these? So you've got 4 sources of allergy data. This one says yes, this one says no. How do you figure this out? And so for the vast majority of these, we actually sat down and wrote all of these rules. It was a painstaking exercise to go variable by variable, but we had to do it. And so then we're left over a year of work with clinicians and source system experts and such, with thousands of lines of ETL code that every night pull from these 50 plus, actually we narrowed it down to about 12 different source systems, that pull from these source systems, go through ETL code, dump it into a central place, and then put into a structured data warehouse that is easy to use for data scientists. So then we actually hired a team of data scientists. And we were strategic in who we hired because we didn't want just computer scientists or just engineers or just statisticians. When we actually heard about all the issues that our end users were struggling with, they did fall into 3 buckets. The first was in comp sci. The second was in engineering, operations research engineering, with a focus on simulation modeling and optimization. And the third was in traditional statistics. In 2016, we launched our research center called CHART, the Center for Health Analytics Research and Training. We spent 3.5 years to build the data warehouse. We started working on projects a little bit before we finished building, and we started implementing them into practice. And our hospital leadership said, whoa, you're actually doing stuff that's affecting patient care and how we manage operations. That's okay, but we're confused now because now you're into implementation. So we're actually going to make you part of the hospital. So as of November last year, I was appointed Vice President of Data Science and Advanced Analytics at Unity Health, and our entire team is now part of the hospital rather than being a quote unquote research entity. And of course, we brought in a whole bunch of analytics tools. We have all sorts of tools like visualization tools like Tableau. We have deep learning servers that we had to bring in because we're still a bit conservative around cloud-based environments. We have software like R, Python, TensorFlow, PyTorch, Simulate, Garobi, all sorts of tools for our data scientists to play with. So how do we actually move from development to application? And I gotta say, a lot of people focus on the research development environment, and we forget the application environment. So when we were building our environment, we did focus on the development environment, but we were very cognizant to say that this pristine environment that is like Pleasantville, it's wonderful, it's what you want to see. Yeah, the hospital's chaos, right? You don't know when that next trauma patient is gonna come in, how their workflow is gonna get affected. And they're gonna have a lot of impure, imprecise data that will flow into our systems. How do we rapidly clean it? Well, we're now moving to real-time systems where the majority of the data that we have now actually has delay of seconds rather than a full day. How do we merge the two? That's the biggest challenge. And the way we merge the two is we basically say our data science team doesn't ask the questions, because we don't know what the important questions are. We're not seeing the patients day to day. We're not the internist or the allergist or the pathologist or the radiologist. We're data scientists. We know how to do our data science, but we don't know the clinical side. Same thing, the clinicians have no idea about the data science, but they know their workflow, they know their clinical environment very well, so we need to work with them. So the process is actually pretty simple. The project ideas come from the ground. The data science team does not ask questions. The end users ask questions. When the end user asks questions, we actually have a template for them to fill. And we assess their questions. We say, all right, can you improve patient outcomes and reduce costs? If you can do both, your first priority. If you can improve patient outcomes at no additional cost, your second priority. If you can reduce costs but not harm our patients, your third priority. And everything else, if we have time for it, then great. And when you fill out that template and you've convinced us, It's not just your idea. You've also got to convince your medical director, your program director, and your division and department head. They all have to support you and buy in before we take on a project. Because it can't just be your idea and your problem. It has to be a community around you that will impact change. That's really what we're looking for. Oh, and by the way, if you've actually brought up the idea, you have to spend at minimum every 2 weeks with us to actually help guide the project, because this is going to be your initiative, not ours, because we want implementation. So there's full buy-in from communities, leadership, and the end user into our entire process. Typical project duration is 3 to 6 months, and at any point in time, we have over 20 projects that we work on. You think this would be a cumbersome process, and most people would say, I'm not playing. Actually, we have a wait list of projects. It's actually been very exciting and encouraging for us. So I'm going to go through a bit of a case example around predicting emergency department volumes. Our emergency department leadership came to us and they said, here's our problem. We need to be able to predict how many patients are going to come to our emerge, because we get slammed with patients, and sometimes it's a lot of patients, and we're scrambling to get an additional nurse to come in because we just saw the lineup and another physician to say, can you actually extend your shift? Had we known a day in advance, 2 days in advance, it would be so much more helpful, because then we can plan better. So we said, okay, yeah, that'll help you, because if we can predict the future in terms of volumes, you can improve your staffing and decrease wait times. Of course, we have data scientists and data to play with, so we use 3 years of historical data. On our emergency department, we scraped in weather data. So is there a snowstorm tomorrow night? City planning data, the Raptors playing at the Scotiabank Arena, or is there a marathon happening on Lakeshore Boulevard? All that data goes into our AI algorithm, and we're able to predict 3 to 7 days in advance with between 94 to 96% accuracy how many patients are going to come to the emerge. So today is Friday. We can tell you Monday from noon to 6, there'll be 82 patients in the emerge. 10 of them will have mental health issues, 12 of them will be high intensity, and the rest will be reasonably easy to manage. With between 94 to 96% accuracy. Of course, the models are just models, right? How do you actually convey that information in a meaningful way? Well, we actually had people come in and design an actual pretty nice looking interface that our staff, our leadership uses 5 to 6 times a day for planning purposes. And that's really what's driven the success around using this information to improve staffing and decrease wait times. Now, this process wasn't all peaches and cream. it was not smooth. So very frankly, I'll start right at the beginning. So a problem, yes, we understand the leadership has this issue. So we're going to be mavericks, and our team will not talk to anybody, and we'll just build models, because we are data scientists. That is what we do. We have the data, we've got these the infrastructure to do it. And then, of course, we're very proud of ourselves. We build these models, and we call in the ED leadership and said, you know, that thing you talked to us about like last month? Yeah, we got some really cool models that we've done, and it's awesome, and we're the best. And of course, they look at us and say, yeah, no, you're not the best. You thought you were giving us something really useful? You really didn't. Because number one, you didn't predict to the frequency that we like, because we work in shifts, and 6-hour interval predictions will be much better than the ridiculous predictions you're giving us. By the way, you didn't even get the patient populations right. That's not really helpful at all. There were so many learnings we had, and we decided it's ridiculous to work in isolation. We can't. So that's where our model of co-creation came in. And we said, you work with us side by side and work with us on a regular basis. That's where we were able to get in useful models. So it fundamentally changed how we did things. We quickly realized that we're using neural networks. They overfit for what you want. They're fine for what we thought what you wanted. But no, we're actually going to use general additive models and state-space models, because they perform way better in what you want to see end users. And that fundamentally shifted how we did things. Of course, then we have to translate to practice. So could you imagine, there's a team of data scientists who are like, yeah, this is awesome. There's a team of end users saying, yeah, this is amazing. But now we get to, all right, well, end users, we built the models, they work well. How do you want to see it? And they say, I don't know, we want to see everything. That was a wrong call, because humans don't think that way. So if you can imagine, we had this visual because people were so data hungry. with over 100 numbers on a dashboard that nobody could fathom. But we co-created it. We're experts in what we want to see, but we're not expert in design or human factors. It was awful. It was hideous. It was horrible. But it felt like home because we created it, and we felt like we did this. So of course, then we said, no, we need a solution development, because I can tell you when we had this dashboard up with over 100 numbers, nobody looked at it for a month, because we know who's logging on to see it. Nobody looked at it for a month. And we had a few surges and we missed it. And the models were very accurate in predicting them, but nobody looked at it. So then we brought in people with design and human factors expertise. And they were very military about it. They said, you're not getting 100 numbers, you're getting 6. What do you want to see? We narrowed it down to 3 big ones, actually. And we had actually other numbers that you could see, but the attention was focused on the three most important ones that they needed. And that changed everything. So of course, as soon as this thing comes up, they use it 5 to 6 times a day, and that's where we drove the changes in staffing and wait times. So I hope that example helps. I know we're going to be running short on time, so I'm going to go through these fairly quickly. There are other examples at St. Mike's. I want to highlight just a few. One of the more recent ones is around a very simple issue. It's not rocket science in terms of analytics, but it's about automating data. One of the things we struggle with at St. Michael's Hospital is tracking our homeless population. These people have no voice, and it's really, really heartbreaking when they come in, and you can't do anything but say, I'm going to manage you, but you're out on your own again, and you really have a shelter to go to, or nowhere really. But the process here is we've got hundreds of these patients. They come in. Our emergency department head, the chief of emergency department, is an incredibly compassionate person, says, I spend so much time understanding, did this person just come in 2 days ago? Because they look familiar. Which shelter did they come from? Because their buddy just came in yesterday. When did they get tested? What was the result? She has to wait hours to get a lot of this information from 4 different groups who then have errors in data entry. It's a terrible process. So we listened, we sat with her, and we said, what do you really need, Carolyn? And she said, here's what I need. And we created a tracking tool that not only automates, as soon as you come in and you put in that patient's medical record number and which shelter they're from, within seconds, it pulls all the data that she needs to make some good decisions, but it also tracks and automatically triggers that within a 24-hour time period, if there are more than 2 patients from the same shelter, it tells her right away, there's a problem at this shelter, there's an outbreak. And in fact, there was an outbreak a few months ago. I'm not sure if you heard it in the popular press, but and it was recognized a little bit later than it should have, because we didn't have these systems in place. Nurse resource staffing team. So this is basically a tool that optimizes nurse staffing. Basically, when you ask a nurse, we have a floater team, and you ask them, how big is your team? They'll say 22. We'll say, why 22? They'll say, it feels right. Well, let's take a look at data around how people actually get sick and go on vacation, and then you got to fill their times. There's all sorts of nuances that humans can't quite grapple with because it's complex. We built a tool that allows people to say, here's how I should optimize my staffing. We've implemented it at 2 hospitals, and the estimated cost reduction is over $1 million. Something very simple, but very useful, and makes people happy because they save money and they become more efficient. The last thing I'll highlight is ChartWatch. Our internist came to us and they said, here's our issue. 1 out of 13 patients in the internal medicine unit will die or go to the ICU. We're not very good at predicting who. And by the time we realize somebody's going to crash, on average, we have 3 hours to react. That is not enough time. So can we predict at least 24 to 48 hours in advance who's going to die or go to the ICU? Because then we can do something about it in a meaningful way. So we have a deep learning algorithm. It's actually an ensemble model where every few hours it ingests data for all of our internal medicine patients. Over 800 variables are considered in this model, and it actually then predicts if a patient's going to die or go to the ICU. We've developed the model, it's completed, it will be launching this summer after extensive silent testing that shows that it works pretty well. The big part is pretty well, because doctors will say, I can do better than this. Well, they might be right. And in fact, there's something called News in the UK that's been implemented in over 75% of hospitals in the UK. It's not an AI algorithm, it's more manual entry of particular variables. When we compared our clinicians to the news, our clinicians beat news. And that's scary to us because news wouldn't help us, it might even hurt us. But our algorithm, we have over 4,000 clinician predictions in real time that we've compared to this algorithm, and we're considerably better. It improves detection by over 20% relative to clinicians at our institution who are pretty good. I'm going to skip through this example and these other examples in the interest of time, but one of these examples highlights a failure that we've had where the algorithm worked well, but the clinical performance we had totally underestimated. And the clinicians were performing way better than we had originally thought with our original questions with our cardiologists. I don't think our cardiologists knew how well the internists were performing. And so it was a failure, and we decided to stop that project because it wasn't adding value. So there are failures. I would say we probably have a failure rate of between 10 to 15%, which I think is actually quite low, but there are projects which we decommission because we don't find they're adding value. So how do we develop a data science implementation model? How do we actually avoid this situation of thinking really big and coming up with something that's maybe not quite so impressive? Something we've learned is that there's probably 3 phases here and 2 models that we really like. The first is around a data science model called CRISP-DM. It was created by IBM, and I think it works reasonably well, and happy to provide references if people want it. And the second model is more focused on implementation, called the Plan, Do, Study, Act cycle, or the PDSA cycle, which has been around forever. But the 3 phases are the exploration phase. Really understanding the issue. Is this a good question to begin with, or is it really a bad question? Have we done our homework to see that there's really a problem? Do we have the right people around the table? Are we looking at the right outcomes? Do we understand your workflow? Because I can predict if a patient's going to die a minute before they die because it's pretty obvious. But if you want me to predict it 24 hours before they die, that's a lot harder because I don't have line of sight of that data 24 hours before they die. So I'm at a disadvantage, but these algorithms have to account for that. Do you have interventions? Because if you basically are predicting something that you can do nothing about, it's nice to know. Maybe the family will benefit, but can you really change the trajectory? No. Is it really going to have an impact? Probably not. So if there are no interventions, why are you doing it? Envision a future state. And of course, explore data feasibility before you start modeling. Is the quality good? Is the quantity good? Then you get into the data science solution phase to actually do the model development, model testing, and AI solution development, which is different from model development. So human factors, people understand design, they come into play. And silent testing becomes really, really important. So shadow trials and those sorts of things that you hear about to make sure that things don't fail when they're actually in practice. And then of course, you get into these cycles of implementation, understanding that you implement, but there's going to be changes and people feeding back. So you're going to have to redo what you've done, tweak things, implement again. There's several cycles that you'll have to go through. So patience is a virtue, and this is not a sprint, it's a marathon. Those were the big things I wanted to chat about. If there are any quick questions, I realize I probably went over, but I'd be happy to take them.
It's Roxana Sultan. Can you hear me okay?
Yeah, hi Roxana.
Hi, Mohammed. That was a great presentation. Thank you so much. Certainly the deployment question is something that's front and center for us here at Vector. And I'm curious about the organizational support for deployment and implementation. Some hospitals and healthcare organizations may have capacity, resources, and engagement, but not all are resourced at the same level to be able to support this type of work. So I'm just curious if you have any thoughts or suggestions around how deployment can be scaled into smaller or, for example, rural or more remote areas where they could really benefit from this type of innovation, but may not necessarily have the resources in place to support that work.
Yeah, that's a great question. I think there's probably a multi-pronged answer. The first is around the solutions that you develop, and the second is around the governance and the culture at the hospital that you're trying to target. And I'll tackle them just very briefly. Hospital leadership and management has to be engaged. If if the culture isn't there, I wouldn't waste your time. It's not going to stick. And I would say not only the leadership, but your frontline workers who actually have to use this information on a day-to-day basis. If they're also not engaged, I wouldn't waste your time. It's just not going to work. My experience has been, and we've chatted with lots of hospitals. We have a DASH network with over 15 GTA hospitals, and we talk a lot with community hospitals as well. A lot of people want to do this stuff, but they don't know how, and they're not resourced to do it. So you'd have to go through this sense of, okay, well, here's what it's going to take for you to actually do it, the buy-in that you're going to need, the resources that you're going to need. But I would then flip over to the questions that you're trying to answer, because there are some solutions that are so low intensity, really will not require much implementation resource. And then there are interventions that will require a ridiculous amount of resource. So for example, our chart watch thing that predicts death and ICU transfer among our internal medicine patients, that's a bear. I would really be skeptical of most hospitals being able to implement this thing. Whereas other tools like our nurse resource team planning tool, oh my gosh, any hospital could do it. It's one decision maker at a hospital around who plans staffing. That's easy. So I would pick your battles and see how ready the hospital is.
That's great. Thank you so much.
Hi, it's Lale. I have a question if you have time.
Sure.
Actually, my initial question, because you give us some example of some trial that have been done in San Michael Hospital. And my question is that, I know that there are lots of bias probably for using this kind of things in practice, and we have lots of algorithms, lots of good papers, but rarely they have come from paper to practice. And that's very important issue. For example, in several countries, like we have the access to good medical things, to doctors, radiologists, and things like that. But we have some countries, for example, they have just one radiologist per 1 million of people. And those countries really, like these kind of algorithms can make lots of change in their community. So my question is that, how long do you see that these kind of things comes from paper to practice? And secondly, not just only like in a hospital that like their management thing has a broad view, like it goes broader and it can go behind the walls of a hospital or two hospitals and papers. What's your perspective?
That's a great question. So in fact, the emergency department volume forecasting tool, where we can predict our volumes days in advance, we've actually implemented that at 4 hospitals now. But we've chosen it wisely. So to your point, maybe I'll use an example here around, if it's as simple as saying, we're going to use your hospital's historical data and your local context of weather and city events and stuff, and actually populate the algorithm with your local environment, easy. In our 4 hospitals, we actually we geotag, so the data is more localized, and we actually use their data for predicting. And we find the level of consistency around the accuracy levels of well over 90% are actually pretty consistent. We're able to hit those marks in each of these. And they're not very hard to implement because you need aggregate data, timestamp data from merged departments. All hospitals have that. So I would say that, yeah, pick your battles. That one's easy. Nurse resource team tool, very easy as well. But when you get to other more complex projects, like the chart watch thing, where you're trying to predict death and ICU transfer, that, you're absolutely right. I would feel very nervous trying to transplant what we built with a large homeless population to Sunnybrook that has a very affluent population with a very different race and gender profile mix than we do. It's not going to work. So you've got to take your approach and try to model it on their data and their context. But simply pick up this model and apply it there, no, it's unfortunate. I don't think it would work.
So I'd like to ask a question if you've got time. I'd love to ask you more about how to implement this all up in Sunnybrook and establish an equivalent body, but that's a very long conversation and probably not a solvable problem. But another problem is, so you've created these models, you've got a very successful emergency room prediction model, So how are you going to keep that going over time? So there's the danger that you've changed the input conditions by actually implementing the model. So it's not like you're just looking from above. You've affected the environment by implementing the model. So how do you go back and check that over time and make sure it stays stable?
It's a great question. That's what makes us really, really nervous. Yeah, the emergency department one, I'm not so worried about, because the thing it predicts is the intake volume. It doesn't predict the management afterwards. So I think we're going to be safe there. But to your point around ChartWatch, where we predict if somebody's going to die or go to the ICU, well, after that prediction, then we actually manage their management, and then that will affect the outcomes. So then what the algorithm will learn, if you keep updating your data, is on that changed environment that now you've actually, and that's a bit of a problem. So there are a few approaches that we're tackling now with other data sets. We're estimating we're probably not going to run into that problem for at least another year or two, but then we'll have to seriously address it. And there are statistical approaches to it. My own sense is I think we're going to need to be creative about how we look at newer data sets. But yeah, that's something we're very worried about.
Hi, Mohammed.
Hi.
Quick question, if you have the time.
Yeah.
So I know that co-development is really, really important, but do you still have some insight on what kind of technologies need to be developed from a researcher perspective that would help from a clinical perspective better?
So sorry, could you repeat that question again? What?
Sure. So co-development is important, and I know that you probably develop models specifically for whatever problem comes your way.
Yeah.
But can you, I guess, give us insights from the researcher perspective who doesn't have as much interactions as you do with the people in the front line? If researchers are just developing the technology,
yeah,
what should they focus on? What can help them make decisions so that whatever they're developing in research can actually be helpful in your case or in anybody who's working in a hospital?
I wish I had a good answer for that. And I've been trying to look for an answer to that question for over a decade now, because you know, I'm probably a bit antisocial compared to a lot of people, and I would rather not deal with people and just do stuff myself and hope that it's useful. But my experience has been, I don't think it can be done in isolation. I'm surprised time and time again, and I have a clinical background, and I still am surprised by the frontline folks who say, yeah, but that's not our perspective, that's not how we look at things. And I'm willing to bet that our clinicians are going to be different than the ones at Sunnybrook, or the ones in Dubai, or the ones in Sydney, Australia. So, you know, I think if you're a researcher who genuinely wants to make a difference, I don't think there's a shortcut to this. You've got to work with end users.
Thanks.
Yeah, thanks, Jens.
Maybe following up on that question. So, you know, we're at this point in time that, generally speaking, AI does not influence the day-to-day of a clinician, right? It's just not true. It just hasn't. But now in Ontario, we have this possibility of the Ontario Health Data Platform. And, you know, I come from the US, and nobody was talking about that level of sharing of data. So we are really positioned in Canada to do something special that nobody else can do. And I wonder, given your past, you know, given your research portfolio and how you've really tried to bridge, you know, computer science and clinical, you know, what do you see in that opportunity? And you know, does that give you hope for the world? And maybe you could just comment broadly on some of that.
Yeah, sure. So, yeah, no, I agree. I mean, AI has this huge hype, and we have this care network that we've established with a bunch of places in the US, including Hopkins and UCSF and Stanford and all those sorts of big players. And it's surprising how we talk a good game, but has it really moved into practice? I am hopeful because I know we don't tout ourselves and beat our chests and stuff, but we have numerous examples where it is used every day to make decisions. You know, again, the example of the ED volume forecasting thing is literally used 5 to 6 times every day to make decisions. So I'm hopeful. With with the Ontario Health Data Platform, and where we're moving with formerly known as Panther, I think there's a lot of potential. I actually just before this talk was in a meeting at that Joint Ministers Roundtable, And I'm very encouraged with the models that they're moving with to really have that engagement of the end users. I do worry a little bit though that if we over process things, that rogue researchers or people who are a little bit more freestyling, I guess you could say, will be, oh, it's too much process, it's too cumbersome, I'm not going to play. And I think the message that I would have to the research community is dial down the ego. There's lots of people out there who could work with this data. Don't walk in saying, here are my demands, if we don't meet them, I'm not going to play. No, that's not how this works. Because there are people who do that, with all due respect to our research community. I think if you genuinely want to make a difference, you've got to go through that process. So what I'm hopeful is that there's two streams here. The first stream is a very disciplined process where you do work with end users. You do collaborate, and you do actually move through that process of co-creation. The second process would be a much more open process that says, we realize there are a lot of good, talented, creative people out there. They may not want to work with people so closely, and they may have their own ideas. Let them have an area where they can explore and come up with really cool ideas. And if they discover something that's really innovative and neat, let's take it. And I think they're considering both, which is really encouraging to me. And the last thing I'll say on this is that the richness of the data that's there is fantastic. There will be, it probably won't happen until December, early next year, until they have a full complement. But I think it will be a very, very powerful platform. I would still caution, though, that not all questions that we may want answered will be able to be answered by these data. Simple things like, for example, we want to know how we actually manage our supply of personal protective equipment, PPEs. Well, we don't have a central database for PPEs. How do we manage it? Can't unless you get that data in. So there's still a lot of gaps.
Thank you.
You're welcome. Right. Any other questions? I know I'm sinking into your lunchtime, so I apologize.
Sorry, can you have access to the slides as well?
Sure, yeah, I can send them over.
Okay, that would be great. Thank you.
All right, no problem. So I'll email them to Tasmi then.
Okay.
Very good. All right, thank you.
Thank you so much.
Thanks for everything.
Thanks very much.
Great.
Everyone have a great weekend.
Thank you.
You too.
Bye.
Everyone.
Thanks, Mohammed.
Thanks.
Awesome.
Bye. That was a great talk.
Thank you.